Good documentation reflects good patient care. So don't let your good patient care be armchair quarterbacked because of your poor documentation. When you come in for a call review because your documentation consists of treated patient, transport patient, and those are the only 2 sentences you wrote, you can expect that they're going to armchair quarterback you. If you write a nice detailed report, you'll be fine. Write a report as soon after the run as possible. And if it needs to be corrected, then correct it. The earlier the correction, the more reliable the change. If you're on paper, so you basically want to write, so let's say you make an error and you need to come back and correct it. You make 1 line through it, you initial, you put the date, and you write what's next to it. Or you basically mark this as an error, and then you say see addendum. You don't scratch out like I'm really bad about, like you can see my O there. You don't want to have that. You cross it out, mark it as an error, initial it, date it, and if you need to, you can write see addendum. If you have a long report, which happens sometimes there are a lot of things that go on, you have a really long assessment, or the story's really long, or you're just being really thorough with your documentation, it's okay to add additional pages. You want to avoid stating diagnostic impressions, although I will say that we do end up doing some level of diagnosis in the field. Ultimately, we have to pick a treatment plan for our patient. Are we going to treat them for chest pain, or are we going to treat them for abdominal pain? So to some extent, we do a little bit of diagnosing, but it's very vague. So we don't want to say patient's having a heart attack if we don't know. Remember MI, myocardial infarction, that's a heart attack. So you don't want to put this, you don't want to put possible broken leg. You want to state, if you think they have a broken leg, why do you think they have a broken leg? You want to state your observations that led you to that conclusion, but don't put your conclusion there. If you have to state a diagnostic impression, do so within your scope of training. So I'm going to teach you that you guys don't get to diagnose MIs. That's something the paramedics do, looking at the 12-lead EKGs. What you guys are going to diagnose is what we call acute coronary syndromes. And that's basically chest pain related to somebody's heart. It's very broad. It's very broad. It's basically tons of different things can cause this, a heart attack being one of them. But you treat them for acute coronary syndromes. You treat them for abdominal pain. You treat them for pain secondary to trauma, or dislocation, that sort of stuff. The stuff that's actually within your scope of training. Don't ever use possible or question mark if the observation would have been obvious to anyone. If you do something to the patient, say what you did, why you did it, when you did it, and what the result was. This is all the stuff you need to document for your treatments. If you do state a particular diagnostic impression or note a particular mechanism of injury, then be sure the treatment you indicate is appropriate. And the next part of that is something should have been done and wasn't, then say why. For example, chest pain patients get aspirin. It may be that your patient's allergic to aspirin and doesn't get it. You don't give it to them. But you need to document that you basically thought about aspirin, that you thought about giving it, and it wasn't just an oversight on your part. If you have a prolonged scene time, say why. So maybe more than 15 to 20 minutes. Just document why. Maybe the patient had to go feed their dog before they go. Maybe you had to stay and help the patient pack her suitcase to go to the hospital. Whatever it is, just document why. If you're documenting times on your report, please do so accurately. So I'm going to talk about the riskiest thing we do aside from driving, and that is patient refusals. Not everyone wants to go to the hospital. That's fine. That's their prerogative. But the problem for us is that we're not doctors. We can't do a complete assessment on them. We can assess them for significant life threats, and we can have some suspicions about things. But ultimately, we're not doctors, and the patient called us hoping to get a medical assessment and probably go see a doctor. So what you need to do for refusal, if the patient will allow you, perform an assessment. So you're going to check them out, check their blood pressure, maybe do a physical exam, listen to their lung sounds, all that sort of stuff. And then try to persuade the patient to accept treatment and transport. So the way you handle this is before you even address whether they're going or not, you say, hey, which hospital can we take you to? That way they know that you're willing and wanting to take them to the hospital. And then if they say, well, I don't want to go to the hospital, the next question should be, well, why not? And if they tell you something like, well, there's nobody here to feed my dog, then it's your turn to try and come up with a solution to that. You need to try and figure out what the barrier is that's keeping them from going to the hospital. If they still insist on not going, then make sure you explain the problem. What's wrong? What it could be. And this is where you're not really giving them a diagnosis, but you're telling them, you could be having a heart attack. Heart attacks can be fatal. Heart attacks can kill you. Or even more scary for a lot of people, it could leave you in a nursing home and unable to speak to people for the rest of your life. That tends to get people to go to the hospital. Talk about the risks of not seeking treatment. Death, permanent disability, seizures, all those sorts of things. Those are good things to throw in there because it's not untrue. Especially if your patient really is sick. It's important to make sure that they understand that it's something that could kill them or something that could permanently disable them. Give them the benefits of treatment and transport. And you can, I would say, talk about the benefits and not just alternatives, but the risks of not going, which is really kind of risks of not seeking treatment. But the risks associated with the alternatives. You know, if you go see your primary care doctor tomorrow, PCP, primary care physician, then it's possible that, you know, the heart attack you're having now could kill you tonight, and you may not make it there. So not just alternatives, but is there a risk associated with that alternative? If the patient still refuses, document the patient's decision, your assessment, your vital signs, everything you got from the patient. Any and all attempts made to convince the patient to accept treatment and transport. Also in here, you need to document the patient's understanding of risks. So you need to say that patient nodded in agreement, patient was able to explain risks back to me. And you can ask him to say, hey, I need you to explain this back to me so that I know you understand it. Tell me that you understand you could die if you don't go to the hospital. And when you actually make them say it, a lot of them will stop and think and go, oh, I could die? I guess I should go. Doesn't matter how many times you just told them that. Once they say it, they get it. Then you're, of course, going to document the refusal, obtain the patient's signature, and a witness signature if you can get one. If the patient will not sign, have the document signed by family, law enforcement, or a bystander. And this is basically somebody witnessing that they wouldn't sign. That's no signature. And that's all I got for you on reports. Come in ready to practice writing. Really familiarize yourself with the subjective and objective information. Make sure you understand that concept. And when you come in, we're going to do a couple practice reports. Thanks, guys.